Reardon, I'm a cardiac surgeon from Houston, and we have a great lunch experience here, so once you get your food, please sit down. We want to talk about the early experience with the new generation Navitor Vision Valve, optimizing implant depth and patient lifetime management. Navitor was launched in the U.S. in 2023, February. It's now being implanted in over 100 U.S. sites. There's been over 1,300 U.S. patients, over 9,000 patients globally implanted with the Navitor valve with really excellent early outcomes. The Navitor low and intermediate risk trial in Vision is starting in March. And then the new Navitor Vision Valve is launching post-CRT. We're going to talk about that today. And it has this really new, nice design thing. There's the 3 dots that go between 3 and 5 millimeters, make it very easy for you to line up the valve, know where it is, and see if you have commissure alignment or not. This is really meant to improve the depth of implantation and allow us to assess for commissural implantation. So we're going to start off. The first talk is going to be by my good friend Paul Mahoney. Paul's going to talk about the new Navitor Vision Valve, design rationale, and procedural benefits. Paul?
All right, thank you very much for the kind introduction, and happy to present the early experience with new generation Navitor Vision. We're going to talk about the specific qualities of this valve, in theory. The slides are around. There we go. Here are my conflicts of interest. So the Navitor TAVI system is intuitive, precise, and accurate with good hemodynamics and durability. The 30-day outcomes that we can report are 0% moderate severe PVL, 1.9% all-cause mortality, 1.9% disabling stroke, 4.2% vascular complications, and a very favorable mean gradient of 7.4 at 30 days. The design of the valve is pretty thoughtful. We got a large cell design, which is useful for coronary access. It'll take up to a 22 French, I believe. Not that such things exist, but it's a large cell design, and it makes manipulation of coronary catheters within those cells much simpler. You can treat an annulus of 19 to 30. It was an active sealing cuff, which is one of the most recent additions, which works with the cardiac cycle and mitigates PVL. The radial force is consistent. It's similar to other self-expanding platforms at full expansion. Intraannular leaflets, which lower the height of the device. And then the most recent additions is 3 radio-opaque markers. These are tantalum markers that are hand-sewn at the bases of the commissure, so they provide commissural information. The bottom of these markers are 3 millimeters, the top are 4.5 millimeters. Access and deliverability, it's an integrated 14 or 15 French sheath with a flexible capsule and atraumatic nose cone. There's a stability layer provided with this. There are no spines with this, as we see in some other platforms, and it tracks and delivers well through complex anatomy. We can show you some challenging cases. Here's some fairly tortuous anatomy. Okay, from access, which you can see here, to the valve tracking pretty easily up and around, and then delivering a very favorable result in an anatomy that would give most operators some pause. Moderate or severe PVL, again, with the addition of the skirt, we feel like that there's been a near elimination or an elimination of moderate or severe PVL at 30 days. This is independent of the size of the diameter, the size of the Navitor. We can see none or trace being the dominant finding, with mild being seen in anywhere from 7 to 20%, no incidence of moderate or severe PVL. The active sealing cuff moves with the cardiac cycle and functions along the base with the annular contact to prevent any significant PVL from occurring. And the hemodynamics are really a hallmark, one of the strong suits of the valve. An intraannular leaflet, but because of the design of the valve, because they open up in line with flow and maximize the orifice area and achieve single-digit mean gradients with a lower profile intraannular setup, because of the unique cylindrical stent. Both the valve design and the leaflet design will be open up to 180 degrees in relation to the flow of blood. And the 30-day Echo Core Lab data shows a 2-centimeter EOA and a mean gradient of 7.4, which I showed in a previous session is durable at 1 year. Proven performance across valve sizes. You're all familiar with these hemodynamic and these baseline gradients and hemodynamics over time, with effective orifice area on one side and gradient on the other side, showing a persistently excellent reduction in gradient and an improvement in the effective orifice area across multiple valve sizes. Very low rates of severe patient prosthesis mismatch at 30 days. This is very favorable when you look at other commercially available platforms. No surprise, it's mostly seen in the very small annulus. It's go down to 23, but even there it's less than 10%, and then it's increasingly goes away as you increase in the valve size. So pacemaker rate, we had a nice discussion earlier during the late-breaking clinical trial about pacemaker rates. In the IDE study, we saw a 30-day pacemaker rate of 19%, which we all consider unacceptable. However, we've seen similar results in other self-expanding valve platforms, and with use of cusp overlap technique and best practices and a recognition of how to implant these valves, we've seen a steady and favorable decline in the rates of pacemakers. We saw an 8.2% permanent pacemaker rate at 30 days in the Arivus LEOView study. The OPTEX study was down to 6.3. We have more recent dual center study real-world experience down to 3%. And we're presenting data from our site later this afternoon showing similar low single-digit pacemaker rates. So I think we, with technique and with best practices, we can get this down to a competitive rate. The one-year outcome after transcatheter aortic valve replacement in patients at high surgical risk, this is something we showed at a late breaker earlier today. On the right, we see the safety and event rates low through 1 year. Again, this is in a high and extreme risk patient population. The all-cause mortality was 1.9% at 30 days, 6.6% at 1 year. Cardiovascular mortality at 1 year was only 3.9%. Stroke rates were 2.3 at 1 year. Acute kidney injury less than 1%. Vascular complications did not change. Bleeding was 6.6%, and the reintervention rate was low. We talked about pacemakers. On the left of this, you'll see some of the things that seem to predict pacemakers. Previous conduction blocks certainly increase the risk of pacemaker. If you came in narrow and in sinus rhythm, you had a pacemaker rate at 30 days of 7.6% and a 1 year of 11.4%. I think upcoming and emerging data will show an improvement to single-digit pacemaker rates across broader categories. The 1 year outcome, again, at hemodynamic performance and low PVL. At 30 days, we saw an EOA of 2.0. That's persistent and durable out to a year, according to the data, and the gradient stayed below 8. Paravalvular leak rates were none or trace. There's no evidence of moderate or severe PVL. At discharge or 30 days, we did have one case of moderate PVL seen at 1 year. Other than that, we've seen no signal of paravalvular leak. Freedom from structural valve deterioration is greater than 99% at 5 years. In an adjudicated registry, almost 1,000 patients, the freedom from structural valve deterioration was 100%. In the randomized controlled trials with 375 patients, it was 99% freedom from structural valve deterioration, which is obviously quite competitive. Gradients, the adjudicated registry, again, almost 1,000 patients, a mean gradient of 6.7 with an EA of 1.8. In the randomized controlled trials, 375 patients, it was 7.2 with an EA of 1.8%. So very consistent and favorable results seen. Coronary access, we talked about this a little bit. Because of the large cell geometry, it allows for both large catheters to be passed through and also a little bit more freedom of movement within the cells, which allows an operator using a standard techniques to engage the coronary with standard catheter manipulation. And you can see it across all the vision sizes, cell sizes would accommodate any size coronary access that you might need. Future-ready index valve. The intra-annular leaflet position allows for TAV and TAV procedures. It's not yet approved for TAV and TAV, but I think we all agree this is a pretty exciting technology for that, and they're going for the indication. Diminished risk of coronary occlusion, diminished risk of sinus sequestration, and it's an ideal choice for a patient's first TAV. It's both a good first valve, which allows you access for the second valve, and it's a good choice for follow-up. The height, one of the reasons is the height of the skirt is 23 millimeters, which is significantly lower than other self-expanding platforms and competitive with the balloon expandable platform at the top of the valve insertion. The Navitor implant technique, I think we're calling it the refined technique, which we'll continue to iterate. But pre-dilatation with this platform, we talked about that a little bit this morning. We think this is pretty important. It is a different valve. It behaves differently, and pre-dilatation is very advantageous. So we pre-dilate with the balloon usually at the minimum aortic angular diameter. Okay? The initial deployment, you cusp overlap view, inflow edge aligned to the annulus, remove the parallax, slow, steady deployment, usually with slow pacing. The deployment, you allow the valve to descend to the annular depth, no more than 3. At 80% lock and check position, at this point the valve is fully expanded, the leaflets are moving normally, and you can take your time and check in both views. You can go from the cusp overlap to the LEO view. Your final deployment, you put a little bit of pressure, centralize your wire, a slow, steady deployment, make sure all 3 tabs are released. We like to pace with this because I think it helps in keeping it nice and steady. But again, we're not pacing at 180, we're pacing at 130, 140. And then final position should be a depth of 3 millimeters or less. Those markers will really help in assessing the depth quickly. They're very opaque. And importantly and excitingly, there's a 35 millimeter valve, which will come in an existing 15 French delivery system. This is called the Titan. I think it'll be called the 35 millimeter on commercial release. And this can treat a broader range of anatomy through a 15 French delivery system. Why is this important? When you compare to other self-expanding platforms, their 34 millimeter delivery system, this delivery size is 15 versus 18, requiring a smaller vessel diameter, 5.5 versus 6.0. The inflow diameter is 35 on the 35 Vision. It's 34 on the Evolute, and the outflow diameter, again, is 35 as opposed to 24. So we think it's a very competitive product for large annuli that require self-expanding platforms. The markers are highly visible. You can see them here. Very easy to pick up. And in comparison to marker visibility, and these are truly commissural markers. They're sewn by hand right underneath the markers. So, all right, and so we'll conclude there. I think I got kicked out.
That seems like a quick stop on you, Paul. Sorry.
That's all right. I've been thrown out of nicer places than this. And then I guess we'll go to our next speaker. Okay.
Well, before we go to the next speaker, we have some discussion time.
Oh,
and
well,
so we're talking about lifetime management, and in lifetime management, of course, we'd all like to avoid pacemakers. You've shown that that's coming down already, and we'd all like to have commissural alignment to be ready for a valve-in-valve if we need it. Talk about with these markers that we have that range from 3 to 5. How do you think that's going to help you in both in getting the implant depth you want and in lining up the commissures?
Excellent question. One of the things, when we talk about commissural alignment, what we really mean is we want to avoid commissural misalignment. In any given situation, you want to avoid having a post of your platform, whatever the platform is, in front of the left main. And so while internal rotation of this device is not present, what you can do is avoid commissural misalignment by looking at the tabs and understanding in certain views. In the cusp overlap, you want to have 2 on the left and 1 on the right. In an LEO-cranial view, you want to have 2 on the right and 1 on the left. And if you can achieve those, you can be reasonably certain that you've avoided commissural misalignment, which is to have a post in front. For those of you who do leaflet modification or basilica, it's the basilica cutting view. You want to go to LEO-cranial view, the left main comes off at a 90-degree angle, and as long as you don't have a single post in front of that, you've avoided commissural misalignment. So I think what it does allow for avoidance of commissural misalignment through using the tabs. In the case that you saw, you have to recapture and come up and go around again. But generally speaking, especially as we move into the Envision trial with younger patients with low and intermediate risk, it's going to become increasingly important that we make sure we avoid this.
So talk to me a little bit, Paul, about we went Boston Shahid presented a case in the previous session where he actually cannulated the coronaries. The other thing that people worry about is coronary access, particularly as these go out into the community and you have non-TAVR implanter cardiologists that get the STEMI in the middle of the night. What's your impression of the ability to get back into the coronaries on these valves?
For the most part, it's standard coronary access techniques. You don't need to downsize your catheters because it's an intraannular design and therefore it's a little bit lower, and because of the width of the cells, usually standard catheters are what you need in standard techniques. You engage with a JL4 or a JR4. You have a little bit more maneuverability within the frame itself to move the tip of the catheter. So it hasn't been much of an issue. Standard things, you have to make sure you watch the catheter go in and out. Do it on floor to make sure you don't hook anything. But for the most part, it is pretty simple to get in and out of these coronaries with this platform.
So Ibrahim, let me ask you a question. So we know as surgeons that patient-prosthetic mismatch is a bad thing. It kills you, it brings you back in the hospital with heart failure and reinterventions. And it's also related to early structural valve retraction. You've seen the hemodynamic data on this. What do you think this is going to mean for the long-term durability and function of the valve for the patients? And particularly, do you think as we move into Envision, which is going to be younger, more active patients, is this going to be an important factor?
I think it'll be an extremely
important Hit your microphone.
Yeah.
I think it's going to be an extremely important factor, and I think it's for all the reasons Paul and you were talking about. This is a really, really good valve for the high-risk patient, but I think it'll be an outstanding platform for the low-risk patient because you really get the hemodynamics. And as you've pointed out, every significant gradient that you have increase across mean gradient or decrease in EOA, that is going to translate into real-world durability. And for an 85, 90-year-old, it may not matter. For a 65, 70-year-old, it's going to matter a lot.
So Wesley, Paul mentioned that this valve is very trackable. What's been your experience with, difficult anatomies and the trackability of this delivery system?
The FlexNav system we've found to be extremely user-friendly. Tortuous iliacs, small diameter vessels, we've been able to navigate with tremendous success and deliver the valve well. The trade-off that you get, or that you would expect, would be a little bit less stability, I think, with that flexibility, but we haven't noticed that at all either in our experience. In fact, the stability of deployment has been phenomenal, and that's what we've enjoyed.
So Paul, one of the knocks against the commercially available self-expanding valve for all ranges versus balloon expandable was, anybody can put in a balloon expandable valve. It's so easy, but it's harder to put in a self-expanding valve. What's been your experience with the reproducibility and the stability of this particular valve, and what do you think is the reason for it?
Yeah, it is easy. It is slightly harder to put in a self-expanding, but it's not hard. I mean, there are reproducible techniques. There's a cusp overlap approach. With Navitor in particular, by the time it's out, it has a little bit more radial strength in the delivery system, a little bit more radial deployment, meaning it deploys from the center out. And so you get a little less guesswork on how it's going to move when you release it. When it's fully functioning, it's fully expanded. You can sort of see where you go LEO to REO, make sure your position is good. The markers are extremely helpful in assessing the depth of your implant, getting the parallax out of the system, and it makes it a very quick process to assess that. So I think this is, there's very few things that are easier than doing this, but this is not hard, and this is well within the framework of any structuralist. It should be something you guys would be good at very quickly.
I would add to that too, you don't lose hemodynamics during deployment, so that allows a lot more time for micro adjustments. So we've found that our recapture and reposition rates have also been lower because of that.
And I think just to
Microphone.
Sorry, you got to remind me. And just to add to Paul's point, it may be more difficult than this, but I think just spending that extra few minutes. If you're going to help with somebody's life expectancy, if you're going to help with somebody's valve and valve take the time. Take the extra few minutes.
Yeah, most of these people have spent 75 years getting to you. So, well, listen, that was great. So we're going to move on.
Thank
to
you,
Ibrahim Sultan. Ibrahim has been one of the lead implanters of going through Portico, Navitor, now into the Navitor Vision, and he's going to share his experience with us on the Navitor valve implantation experience. So, Sultan.
Great, thank you so much. Thank you again for allowing us the opportunity to share some of our experience. So Paul went over a lot of data. I'm going to just share two very, very basic, simple vanilla cases. So there's nothing exciting about this, but I just would really like for everyone to appreciate what technology allows us to do, meaning basically make it so simple that even with minimal experience, you can get a really good implant and, more importantly, a really good result. So this is kind of a standard patient with severe symptomatic aortic stenosis, 80-year-old woman with peripheral arterial disease, COPD on some home oxygen, prior coronary disease, so again, coronary access being important here. Subtotally occluded right common femoral. The heart team thought she was at high risk for traditional open heart surgery. So reasonable discussion. Stenotic valve. These are what her measurements look like. Again, we tried, just like most of you, we try to do these ourselves and compare. And early on, there's not a significant discrepancy of what you'll see with this platform. It's just looking at simple things like you would for any self-expanding valve, whether it's sinus segments, coronary heights, apart from annulus and LVOT. And there's really no major watch-outs here. The sinus segments look like they would accommodate a valve reasonably. Coronary heights look very, very reasonable, and this is what the calcium burden looks like. And see some significant narrowing on the right side. Could potentially Rambo something through it, but not worth necessarily going down that, so we decided to go through the left. Not significant angulation. This is another thing we've noticed with this platform because of the lack of because of, from a spine perspective and the ability to really navigate that torsion. Paul gave you a great example. You're really able to take very, very steep angles and do this in very horizontal anatomy patients. So a 27 Navitor Vision Valve, and this is the particular valve that has those 3 markers that has allowed us really to have, not only have a more predictable deployment, but we've actually learned from this. Because when you see this valve deploy and you see where it moves, how it moves, you can actually tell based on the marker and where your diagnostic pigtail is sitting, how it's going to conform and behave, which has been very promising. We've migrated using circular wire, very similar to a safari wire, pre-curve. We use a radial axis pigtail. We still put a temporary pacemaker in. We do fast pace, not necessarily rapid pace, but about 120 to 140. We do pre-dilate 100% of these patients. And again, it just allows us to prep the annulus and allows for better conformity of the valve. Because again, the opening force may not be as exaggerated. In the end, we know that the radial force is appropriate, but it allows for better opening force. The pigtail is obviously not down all the way, but you get a good diagnostic view and a cusp overlap technique, ensuring that, valve is appropriately aligned. Once you cross the valve, that's the circular wire that we're looking at. We try to stay as aortic as possible when we're doing our BAV. We use the minor axis for the most part. You could be aggressive, use the mean or whatever you're comfortable with, but we typically use a compliant balloon, use the minor axis. Again, the purpose of this is to create a scaffold where you could land and deploy the valve appropriately here. This is something that I remember learning from Paul. Because of the hardware in the nose cone and elsewhere, really take your time and don't descend too fast as you're coming in. You can start fast, rapid pacing, and you'll see how the valve doesn't move tremendously, even with fast pacing. Again, a lot of operators have deployed this really without pacing at all, and you could do that, but why not when, again, the valve is functioning right away? You could avoid pacing altogether, and you'll see how it opens both on either side. Now, one of the things you'll notice is we don't deploy these at 0 or 1. You don't have to, and again, I think this goes back to the coronary access point that Mike was trying to make, and you could do this very comfortably and still allow for low risk of pacemaker, good coronary height, potential valve in valve, not relevant to this patient population, but again, these dots, which are very radiopaque, or almost I'd call them obnoxiously radiopaque, really give you a good view. We've noticed that you could even use less dye potentially in some of these patients. The leak rate has almost disappeared with Navitor technology. Quite frankly, we haven't really seen moderate PVL in I don't know how long because the active sealing cuff. Again, single-digit gradient. This is not just consistent just based on invasive gradient, but on echo gradient at 30 days. And in the midterm, we've in fact looked at this at, at an average of 3 months for intraannular self-expanding versus supraannular self-expanding versus balloon expanding. We've noticed, and we've presented this at TVT last year, which is that the intraannular self-expanding valves, such as Navitor, tend to behave more like supraannular valves when it comes to hemodynamics. That's what we're looking for. That's what we want. So it really gives you the best of both worlds. Another patient, very similar, frail, walks with a cane, had a prior mid-cab, of note, does have a right bundle and a left anterior circular block, so something to be cognizant about. Measurements all within careful parameters, generous sinus segments, good coronary height, significantly calcified, and wide open transfemorals. Angulations, again, not of concern. This is what our diagnostic picture looks like. Again, heavily calcified valve. Mammary was open when we interrogated it. We planned for a 25 millimeter valve. You could potentially stretch this to a 27, but a 25, very small, petite man. In fact, 25 millimeter valve was more than adequate. Right transfemoral axis and a pre-BAV with an 18 millimeter Z-med. This is us again doing our pre-BAV like we usually do in these patients, ensuring that we get really good opening force. Again, try to stay a little bit more aortic, avoid the bundle as much as possible. Again, slowly descend. Now, in the past, another platform, you almost have to count on the valve descending by itself because of stored tension. You don't have to do this here. In fact, where you start is where it's going to end up as long as you don't have any stored tension left behind. And the number of pictures you take really is minimized when you're looking at that. And if you use those dots as your marker and you end up at 3 millimeters, you're going to be in really good shape for the most part.
Can you comment on the two pictures there, your coplanar and your overlap picture and your dots? Or are you going to come up with that later?
Yeah. So this is what I would just say mental math we like to do when we don't have too many cases, going in different views. But the first view we predominantly do is we just go to our cusp overlap view like most cusp overlap operators have done. And we deploy and we make sure that our non is good. And then we essentially go to our LAO-cranial or straight LAO view and see where the left looks like. And obviously don't pay attention to the non. Your final picture could be, you could use your coplanar as if you're splitting the difference, if you're concerned whether or not you're appropriate in the cusp overlap or not. There we go. Excuse me. This is again our deployment. Oops, that didn't work. This probably went down about 1 millimeter or 2 more than expected, but again, patient was able to get discharged. Again, we've seen him past 30 days, no conduction disturbance despite being at that depth, single-digit gradient, and no PVL. So, Paul mentioned this. We've seen this in our experience ourselves, and we started with Portico Flex Nav onto Navitor Flex Nav, and we had a double-digit pacemaker difference, and really just with anything else. I don't know, I think, Mike, you said it very elegantly in the last session, which is, this is operator dependent. We can help influence this. And we have, I think, just with experience, learning, and really being meticulous about it, you could really get down to single digit, as many folks have done with different platforms for self-expanding valves. And if you continue to do that, use appropriate methodology, do a good BAV, good positioning, you're going to be down to a single-digit pacemaker gradient, as is seen really in multiple cities over and over again. And we've seen this again with the latest PME as well. So in our experience, where do we think this shines? In patients with horizontal anatomy, you do have some predictability with deployment. And marginal vascular access patient tortuosity, it helps with deliverability. In small annuli, this is where hemodynamics are really important. You get kind of that supraannular hemodynamics in an intraannular valve. And alternative access, whether it's carotid or less subclavian, really allowing stability during deployment. Most, if not, really no TAVI platforms are created for alternative access, but it really behaves quite nicely during alternative access as well. Thank you. I'll stop there.
Well, good. That's great. Thank you, Ibrahim. But I've got a series of questions for you, sir. So first of all, the issue of pacing. We pace at 120, 140 when I do any of my self-expanding valves, and a lot of my fellows get worried about that, and I keep telling them, well, rapid pacing at 180 makes you feel dead. Fast pacing at 120, 140 just makes you feel like you're in love, unless you have a bad RV or a bad LV. Yeah. So for all of us up here, how many pace when you deploy your self-expanding valves? Okay. Well, it's just important for the audience to know that really is not a negative to pace at 120, 140, unless there's a reason not to do that. These are both kind of interesting cases. They're both fairly small anuses. A woman, 23.5, a man, 21.9.
Yeah.
So as a surgeon, if you had to operate, if he was a surgical candidate, you're going to be doing an annular enlargement on that man.
I don't agree with that, because this is a 30 millimeter sinus segment. You could comfortably get probably a 25 millimeter surgical valve in, because it sits supraannularly, so you have the data, but I agree with you.
You may, but the surgeons I see in my community would come out with a 21 valve.
Yeah, no, and that's a problem, right? And so what are you offering this man who's had a prior CABG, patent lima? You're only going to hurt him potentially with surgeries.
I think it's really important to kind of look at the concept of what the hemodynamics you're going to bring. I often get asked by cardiologists, I have somebody that's on the borderline, they could go to surgery, they could go to TAVR, what should I do if the patient's okay with either? And one of the things I tell them is, well, tell me if you send them to surgery, what is your surgeon sending back to you?
Yeah.
If your surgeon's sending back 19 and 21s, you should just have a TAVR, because these valves will produce good hemodynamics in that.
100%.
Or just get a new surgeon, which is probably a better option, but that's a separate issue. Talk to me about pre and post dilatation. How do you choose your balloon size for your pre-dilatation?
Yeah, so we've done this experiment a few times, and I'm not quite sure it makes a difference, is the short answer. But what we've done for the sake of consistency is we know that if you use the minor axis and you use a compliant balloon, you're able to get a good BAV without putting excess force, without hurting the septum in the process. And I think it allows the valve, particularly the opening force of this particular platform, allows the valve to really catch on comfortably.
It's a trade-off, really, because one of the advantages of self-expanding platforms is no risk of annular rupture.
Yeah.
Yep.
So the only risk of annular rupture comes with your true balloon pre
Yep.
or post-dilatation, because that's what's going to do it. So the more lesion prep, the more aggressive you are with your pre-dilatation, probably you're going to have more single deployments and more ease, but at the risk of exposing the patient to that thing you wanted to avoid in the first place. So I've evolved a little bit. Like you do, depending on what balloons we have, if we only have true balloons available, I'll go to the minimum or less. With a softer balloon, I'll do the minimum, maybe +1. But it's a constant kind of battle back and forth between safety and efficacy. You know?
Yeah, we use trues before and after. I know Raj McCard used a true before and then he uses something like a Z-Med after because it's more compliant. I personally think as long as you choose the right balloon size. So let me ask you all another question. So post-ballooning, how often do you find that you have to post-balloon one of these?
Less than 10% of the time. Yeah.
I'd say 10 to 15% of the time, but I'm conservative on the pre-dilatation.
I would agree. So depending on your pre-dil balloon, I've actually increased the size of my pre-dil balloons when I don't have a lot of annular calcium or LVOT calcium to kind of push it more towards the average diameter, not quite the max. And I find that I have less post-dil in that setting, but we're still probably 10, 15%.
Well, I'm old. I lived in the era before we were doing TAVR and we were doing just BAVs. And we did a lot bigger balloons, and that was all we were going to do. And we didn't rupture too many annuses. So I think we're all become very conservative. So now the next question for all of you. Posting. Posting is important when you need to do it. I personally don't think that it done right. It's related, it has any real negative consequences. I mean, sometimes you may get a conduction defect, but they often get better. What do you think about posting? Do you think that's something people should be afraid of?
No, I mean, I think people should be afraid of leaving moderate PVL alone. I don't think you should be afraid of post. I think if you're careful, thoughtful, you pace well, you're going to be in good shape. So,
Yeah, if there's significant PVL, they're getting post-dilated.
Yeah.
You know, the rare exception may be a 90-year-old, but for the most part, if you need to do it, you need to do it, because we all know what happens if you leave the lab with more than mild PVL. It's not great. So we go ahead and post-dilate.
Wesley?
Yeah, we're certainly not afraid to post-dilate. In fact, I'll show a case in just a minute where we did, and we do routinely if we need to, if we see almost any amount of PVL, and we're not high risk for a pacemaker.
So most of us will always balloon if there's a significant amount of PVL
Yeah.
or if there's a gradient. This
Yep.
on hemos, there should be
Yep.
no gradient in this valve ever. If the lines don't match, something's wrong. But maybe we can talk about this after Wesley. What do you do if the valve's not fully expanded, but there's no PVL and there's no gradient? I think that those are bad valves. But let's move on, and Wesley's going to talk to us now about 35 millimeter Navitor Vision Valve implantation experience, the new Titan valve. So Wesley.
Thank you. So good morning, afternoon rather. Make sure I can do this quicker. My name is Wesley Lane. I'm practicing at the Arkansas Heart Hospital in Little Rock, Arkansas. We've been using Abbott platform since FDA approval of the Portico system. We actually started in early 22, and then when Navitor was released in 23, we've switched over to the Navitor. And recently, we're involved in the post-market analysis for the Vision valve, and that allowed us some opportunity to use the larger format 35 millimeter Navitor Vision valve, which was called the Titan valve, but we're going to call it the 35 millimeter Navitor Vision for now. These are my disclosures. So the case that I'm going to present to you is actually coming fresh from last week. I switched my case that I had prior to this one because the outcome was neat, and I think it highlights some of the specs of this valve where it really performs well. Patient's 88-year-old white male with hypertension, renal disease, atrial fibrillation on a NOAC. He has moderate non-obstructive coronary disease with remote PCI. Main symptoms are heart failure with preserved ejection fraction with a baseline NYHA class of 3B. He's had multiple hospitalizations within the last year just treating his heart failure. He's also got some angina. I had an STS slide on there, and it may still come. But his STS risk was about 11% due to age and comorbidities, so he was deemed prohibitive surgical risk. This is his echo, so a tri-leaflet, heavy calcified aortic valve with severe leaflet restriction and immobility, preserved EF, LA enlargement, and hemodynamics consistent with severe aortic stenosis. Here's his STS data with some pertinent labs listed on the left. and the operative mortality at 11% on the right. Busy slide with a lot going on, but I'll highlight that the perimeter, annular perimeter is almost 90 millimeters with a annular area of about 620 millimeters squared, which is far beyond the 29 platform. So we were happy to have the Titan valve available. Coronary heights are appropriate. Left is just over 15 and the right is over 19, so shouldn't be a problem for us. And he has a nice LVOT without severe narrowing. We don't have a big septal bulge or any LV issues that should pose problems. Significantly calcified leaflets that you can see on the left, and then if you look at the right, he does have some calcium that extends down into the LVOT, which can pose some risk for paravalvular leak, and one little segment of nodular calcification in the non-coronary cusp that you see there too. So there's the parameters and the specifications for the Navitor 35 millimeter platform, so you can see fits nicely within those specifications. No issues with access, more than enough access to accommodate our minimal 5.5 or 15 French sheath. So this is our typical approach. Every time we do a self-expanding, we kind of approach it the same way. We'll take two scout views, and especially in somebody with renal failure, one of the things that we've enjoyed about the vision technology is that it really helps to minimize contrast usage during implant, gives you an extra degree of certainty about your depth without having to continue to puff and puff and puff and puff. So we'll take a scout shot in the coplanar view or the LAO typically, and then the cusp overlap view, which is typically RAO caudal or AP caudal. And we'll use those for a map, if you will, during the case. We'll do our pre-hemos to check the LV EDP and peak-to-peak gradient here, which was about 40. And then posting, I actually put 26 true. That's a typo. It's a 25 true, which was our min. We've already had that discussion a little bit. Most of the time, we'll go with the minimum, especially in this patient who actually has a right bundle branch block that I don't know if you caught earlier. So we're trying to be a little more conservative in his case. So there's our scout shot on the left. We kind of use that as a reference, and then we'll deploy at 80%. So deploy to 80. Similar technique to what's already been presented. So at 80%, we take the opportunity now to check an echo. It was mentioned during the last presentation, or the last session, that the nitinol valve does take a little bit of time to kind of warm up. So while we're waiting for the nitinol to warm up, we like to stop and check an echo and just confirm our depth. So here on the non-coronary and the right cusp, I can see that the valve borders are just exactly where we want them, about 3 millimeters depth, not interfering with the mitral apparatus or the anterior leaflet at all, and not quite all the way down to the membranous septum. After that, we're satisfied with our echo. I'll then roll over to an LAO projection, either in the LAO spot for coplanar or LAO cranial, and just confirm our implant depth. So on the right, you can see the left coronary cusp, just confirming our valve borders are appropriate under the left cusp there. We'll then move on to complete deployment. We usually leave it in the LAO projection for deployment as long as there's no parallax in the valve. Occasionally have to move a little bit to take that out. Pull the wire back to centralize the nose cone, and then deploy fully when all the posts separate from the valve. We'll then check our echo again. So after initial employment, for this patient, you'll note on the first echo picture there's some flow where the wire is crossing the valve, but he also has a little peri-device flow right where that calcium spicule was located. And then on the long axis, you can see similarly, trace to mild. It's not a significant leak. You can certainly leave it here, but he has a little bit of leak on the other side of the valve too. So we did decide to go ahead and post it. That's become routine for us with almost any amount of paravalvular leak. We'll try one size up. So we went from a 25 to a 26. The average here, I think, was a 26, and his max was a 28. High risk for a pacemaker, and as you can probably tell, we're actually riding the pacemaker now during the case. So just trying to get a little bit better here. Went ahead and post-dilated with the 26, and then after post-still, complete resolution of paravalvular leak and a post-implant gradient of about 2 millimeters of mercury. He leaves the lab with the pacemaker. That's the final shot of the valve. But fortunately, by the time he got to the floor, he recovered his conduction. The temporary wire was able to be pulled later that day, was discharged home the following day, did not require a pacemaker implant. Single-digit gradients and no leak, and that persisted to the next day. So post-implant gradient here, average of about 5 on the left, with absolutely no paravalvular leak present on the next day echo. He did great.
Wesley, thank you. That's a great presentation. But I do have some questions for you. So, first of all, with the earlier self-expanding valves, the larger sizes were often thought to be more difficult to put in. I think that's gotten better over time. But what's been your experience with the Titan valve versus the smaller sizes of the Navitor? Does it implant the same way for you? Do you have to do anything different?
We pretty much have done it the exact same way for the 3 that we've implanted. Our 4th is actually tomorrow. So for the 4 Titans that we've implanted, the stability of deployment has been similar to the other platforms. We've not yet had to recapture and reposition, so we've experienced a great result.
Yeah, for
All
me,
3 times.
it deploys the same way and it
Yeah.
deploys in the exact same technique. The biggest adjustment you have to make is visual because it's really big. I mean, there's no waste in it. It looks like a spaceship. And you sort of think you're on the wrong mag for a minute, but it deploys, it's stable, you can put it where you want it, it's a very nice platform, and we've been very happy with it.
Most of the anxiety is getting to the deployment. It actually is surprisingly similar to the other sizes.
So let me ask you guys a question. So this guy comes in with a right bundle and a left anterior hemiblock. His odds of getting a pacemaker are greater than 2/3. But if I go to my EP guys, they won't put a pacemaker in because he doesn't meet the criteria unless I put him on a Holter monitor, and then sometimes they do. What are you guys doing with somebody like this? Because if he gets a pacemaker, which he has a high chance of, even now being alive, without a valve, he has a high chance of it. Are you guys doing Holter monitors? Are you talking to your EP guys? How do you handle this?
So in our institution, it's the same deal. They will not get a pre-pacemaker. I think post-TAVI, we would typically send them on a Holter if there's any concern at all. But again, if anything looks concerning or funny, we have a very, very low threshold of putting a pacemaker in. I mean, particularly in these elderly population, we wouldn't want to send them home.
Yeah, it's a frustrating situation because from the EP standpoint, no one's counting their pacemaker rates. So, they're like, well, just put it in and we'll take care of it later.
They get RVUs for it.
Right, well, but, take a careful history, look for any history of passing out or lightheadedness. We'll do a 24 to 48 hour Holter monitor looking for it. The yield of that is unfortunately not great. Occasionally you'll find one, but it remains a tough problem.
Wesley?
Yeah, we don't routinely do pre-monitoring for these patients, and certainly we haven't convinced EP that they need to put in prophylactic pacemakers yet. But this patient and patients like him will discharge from the hospital with an MCOT monitoring system who are very high risk.
Yeah, if I do one like this, we will send him home on home monitoring.
Yeah.
Because the chance of something happening in the first month in a patient like this tends to be fairly high.
The one category I think that you have some negotiating ability is if it's a right bundle greater than 150 with first degree AV block greater than 200, that probably means they should have a pacemaker.
Sure.
So there are certain really high risk categories based on the baseline EKG that you might get away with that, but you need to have a discussion with your EP guys.
Sure.
So I work at an academic place, and I have one cardiology and one surgery super fellow doing this with me that have, kind of surgeries finished their training, cardiologists finished their interventional stuff. And so we, on every case, we do hemodynamics, we do a surface echo, because we have an echo machine in there, and we do an arteriogram. And it's actually been somewhat helpful besides as a learning tool, because early on, before we had cuss overlap, we'd always do a no color long axis, and we'd think we were at 3 millimeters, and we'd go, why is this down to the hinge point of the mitral valve? That's 6 millimeters down there. And we realized that, something was wrong. It wasn't until, Hemmel and others came up with the cusped overlap that it really dawned on us what was going on. But it also served the second purpose of, I'm convinced with self-expanding valves, you need to not rush through this and give them a little time to expand. And when you're at 2/3 while you're just sitting there, and people that are operators of any kind, whether they do it with a catheter or with a knife, don't like to sit still. And so having an echo gives you something to do that keeps everybody occupied for a couple minutes before we release this valve. I mean, do you guys do anything like that, or you just, how long do you wait before you release your valve?
We do, and I think that's a perfect time to bring in echo or to check hemos or do something like that while the valve warms up. It's an exciting time for TAVI because we've enjoyed such success with all three platforms really that we have available commercially here in the U.S. that now it's style points, right? We really are figuring out how to accomplish precision deployment, and it's the little things like monitoring hemodynamics, not losing hemodynamics and taking a little extra time during deployment, because that extra time is likely paying dividends on the back end without having to recapture, redeploy, reposition. And so I think that's where we'll go.
Yeah, I'd echo those comments. I mean, there's a lot of clubs in the bag now. There's a lot of ability to pick the right valve for the right patient. We have CT scans that tell us everything. So, you know, being good at implanting these, understanding the indication, understanding it, just as Wesley said, I think is part and parcel of being a good structural operator.
Yeah, and I think as technology gets better with all three platforms and more platforms to come, I mean, this is really good for patients. I mean, it's good for operators. It's really good for patients because, you know, our ability to get to, I like the term precision deployment, it gets easier and easier. And, you know, we're moving from pacemakers, looking at left bundles now. So, you know, the bar will keep changing, and we just have to keep getting better and better, which is great.
So let me bring back up something that I said I was going to bring back up, and that is under expansion of valves. Now, night valves have the advantage that they continually push out. And I remember in the very early days of balloon expandable and the core valve, a lot of my partners' friends said, well, you know, this night can't push calcium away because calcium's too tough. And I'd always ask them, do you have kids? And they go, yeah. You have kids that get braces? They go, yeah. And then it would dawn on them that, wait a minute, if you push for a long time, you can move your teeth, you can move anything. But I do think that occasionally we are letting these people leave the lab, even with balloon expandables, with under-expanded valves, like people are going back to a double tap on balloon. So what do you guys do if you roll over from LAO to RAO and it just doesn't look expanded, but there's no paravalvular leak, the gradient doesn't look bad? I personally hit those valves, but what do you do?
Same. So we've had few episodes like that, but occasionally you'll run into some infolding or valve restriction because of LVOT features. In those instances, we've posted almost every.
So, you know, God is in the details on that. I think in a high and extreme risk population, if you have no gradient, you have no leak, I call that a good result. Yeah. You get to the 72-year-old patient and you want a perfect result. You want to circularize the valve. You want to prepare for the next one. You don't want pinwheeling. So for those, you know, the aesthetics of how the valve looks matters, and I'd be much more likely to post-dilate that one.
Thank you for looking perfect result in 72-year-olds because they're very young.
And I think there are times where you look towards the non, and when you roll over, that it is jammed against the non-sinus, right? I mean, there's only one way to go, and you don't want to go that way. So I think, you know, looking at different views, reassessing, particularly when there's no leak and no gradient, I think you got to pause, take one more look before you do it.
And let me ask you another question. It's a little off the beaten path, though. I'm responsible for the finances of my TAVR program. In fact, my whole cardiac surgery program. And you know, most of us work on pretty thin margins. What's been your experience with the contribution margin using this valve? Has it been better, worse? What do you think?
It's been extremely favorable in Arkansas. Our reimbursement there is quite a bit lower than most states. And so when we started using Portico and Navitor, it's taken our margins to a much more favorable place. So we can come to administration now and bargain, which is nice.
Yeah, I'd iterate that. It's been very helpful. It also gives the appearance of you're engaging and trying to be a good partner with the administration, taking a very good valve platform and trying to work it in if there's some cost savings. So.
And the hope is with more and more platforms, I mean, the prices will continue to drop down. Hope. I'm not sure if it'll actually happen, but yes, I think overall our contribution margins have increased. So.
Well, a really great session. Any questions from the audience? I mean, I hope somebody gets up because I don't have to come out there and start asking questions. Oh, no questions. We stunned everybody into silence. Well, that being the case, I want to thank my panelists, Dr. Mahoney, Dr. Sultan, and Dr. Lane, for giving us really a great session. This is an exciting new valve. These markers really are very, very helpful, particularly for somebody my age, to line these things up. And I think you can see that the experience with this valve has been very good. So thank you all for coming. And we're going to end a little early. And the definition of a good meeting is it ends early. The definition of a great meeting is it ends early and has food. So this has been a great meeting.
Thank you.